Welcome to our virtual prostate cancer awareness event. I'm Darren Duarte, and tonight's program is brought to us by the Brockton area branch of the NAACP in partnership with AdMeTech Foundation. For more than a quarter century, AdMeTech has been advancing patient care and saving countless lives. Helping me host tonight's event is the second vice president of the Brockton area branch of the NAACP, Leona Martin, along with co-host and AdMeTech community coordinator, Erin Roberts. Two women committed to ensuring that men not only survive this disease, but making sure that we men are armed with facts and information so we are better informed about the disease as well. Leona?
Yes. Hello, everyone. Good evening, and thank you for being here. It's nice to see so many familiar faces, and there are some new names that I see here, but it's always great to have everyone join us. And I just have to say that I am just so grateful for the partnership that we've had with AdMeTech. I can't get on any of these programs without bringing up and remembering when I first met Dr. Faina Stern at a NAACP meeting, which is the New England Area Conference, maybe around 2015. And after the presentation that she did, I ran over to her and introduced myself and brought her over to meet Steve Bernard, who was the president at that time, to say, we need you to do this work in Brockton to support our community and just the men in the city to do what it is that you've been doing, because it's important work. So I'll stop there, but I just can't help but bring up that story because, and the rest is history pretty much, from when we met her, and it's been a great partnership. Erin?
Leona. Hello, everyone. My name is Erin Roberts. I'm also part of the AdMeTech Foundation team as one of the community coordinators for the Prostate Cancer Equity Program. I've also been with the team for about a year now as one of the featured speakers, and I actually get the opportunity to co-host with Darren and Leona. So I'm very, very happy about that. I'm so happy that everyone was able to join us this evening. And please write down and submit through the chat any questions or concerns you may have regarding prostate cancer or even the Prostate Cancer Equity Program. And Darren, back to you.
Thanks, Erin. We hope everybody stays with us through the entirety of the event because we have a pair of Celtics tickets to give away, and we have 2 Y family memberships. We're going to do that at the end. So the lucky winners stay on. Could be you. It could be you. Well, many of you are joining us on Facebook and others are on the Zoom call. We just ask that you mute yourselves unless you're on. And if you have a question, there's time at the Q&A section at the end of the program to ask your question. So of course you can unmute yourselves there, because we want to encourage everybody to participate, because we want you to leave here knowing how to protect yourself, how to protect your friend or family member who may be at risk of having prostate cancer. As many of you know, cancer is fought on many fronts, many fronts. And later, our medical professionals are going to talk about some of the cutting edge advances in prostate cancer care. But members of our state delegation also fight this disease on a front that they're very familiar with. They help us secure funding up on Beacon Hill. And sometimes that's not always easy. Prostate cancer affects all men, but it affects Black, Hispanic, and Latino men at a higher risk. And I should know because I'm one of them. This program, AdMeTech Foundation, and with the NAACP, I really owe my life to them. I would go to these events, listen to it, but I didn't take much action. One day I did and found out I had an aggressive form of the disease. 5 years ago, luckily we caught it in time. This is an important program. We want to thank our lawmakers for making this possible as well. State Senator Mike Brady, if you're on.
Yes, how are you?
Good. Say hello. We just wanted you to say hello and thank you for helping us with securing funding and so forth. So,
well, thank you, Darren, and I'm glad you had good news on your health situation, but we've known many friends, especially on this Zoom meeting tonight that have been diagnosed with prostate cancer, and thank goodness that they've recovered. And we were able to get money in the budget this year, $1,250,000, and $250,000 was vetoed, but we were able to override that veto with the House of Representatives and the Senate. So the full $1,250,000 was put back in the budget, and we were able to get that passed this year.
We want to mention State Rep Jerry Cassidy, Rita Mendez, and Michelle Dubois for the work that they did.
Yes. So I have the distinct honor at this time to introduce our wonderful mayor of the City of Champions here in Brockton, Massachusetts. He has been a supporter, a friend, and just a champion overall in all the work that we've been doing here in Brockton, educating our community about this dreadful disease. And the beautiful thing too about the mayor is that he has shared with us in the past that his father had this disease, which makes it all that much more personal for him. So clearly he is somebody that we want on our team. So without further ado, I introduce to you Mayor Robert Sullivan.
Good evening. I want to thank Leona and Darren and Aaron. I want to thank the Brockton area branch of the NAACP, and of course the esteemed President Phyllis Ellis, and all the membership and all the officers. I want to thank, of course, Dr. Stern and the team at AdMeTech Foundation. But quite honestly, I just want to thank each and every one of you. As Leona said, I'm the son of a cancer survivor. My dad was diagnosed 8 years ago, and he's 83 years young this year. And it was always about early detection. But before I talk about that, I want to thank Steve Bernard. I was a city councilor at large, serving the whole city for 14 years. And Mr. Bernard came to me and said to me, Bob, did you know that African-American men get prostate cancer at a lot higher rate than Caucasian men? I didn't know that. And so I looked into it. And due to the awareness and the education by the NAACP, this forum is saving lives. You know, we can talk about so many different aspects of cancer, but prostate cancer is curable if found in an early stage. And as the son of a cancer survivor, I'm extremely proud of everybody coming together, all the medical clinicians, but quite honestly, it's about awareness, right? But it's also about not being embarrassed. Get tested early, get your PSA numbers. That will save your lives. Now, we are going into the holiday season, and my humble suggestion is the best gift that a man can give to himself and his family right now is to get tested. Go see your primary care physician, and you will thank yourself, and your family, your loved ones will thank you. Because if you take the right steps, as Darren said, and Darren's proof, if you catch it early, you will survive this deadly form of cancer. So again, I just want to thank all of you for what you do to better Brockton, to save lives in the City of Champions, in the region, in the Commonwealth. The state delegation has been wonderful getting funding for this very important cause. And again, I just want to thank, not as mayor, but as a lifelong Brocktonian, I just want to thank each and every one of you. Now, we have a lot more work to do here, and we will continue to fight the good fight against prostate cancer, and it's about awareness. So again, I thank you for your time tonight. I will not be around for the Celtics tickets because I have to go to the school committee meeting tonight at Brockton High School. But again, I want to thank Dr. Stern and AdMeTech and everybody here tonight. Because when you talk about your personal experience with prostate cancer, it rings true. It really touches who you are as a human being. So God bless each and every one of you. Thank you, NAACP, for what you do to better Brockton. And again, have a good evening. Thank you.
Thank you, Mayor. Thank you, Mayor. Here to introduce our keynote speaker / expert presenter is AdMeTech's Aaron Roberts. Aaron, thank you for all you and your colleagues do to support this program.
Thank you, Darren. So moving forward, I would like to introduce Dr. Sean Waser, MD, faculty member, Division of Urology and Associated Physician, Harvard Medical Faculty Physicians, Milton Center for Specialty Care, and Needham Urology Associates, Beth Israel Deaconess Medical Center, Beth Israel Leahy Health, and Harvard Medical School.
Thank you so much, everyone, for the kind invitation today, and especially Dr. Stern. Happy to give these these talks. And today what I want to do is just something a little bit different. How do I approach men that come to see me with prostate cancer? No disclosures. This is dedicated to my grandfather. He had metastatic prostate cancer, grew up in Barbados, died many years ago. And back then there really wasn't much of the the screening that they had today. And so we're fortunate in living in an era where, we can diagnose prostate cancer very easily and we can treat it very easily. I was just going to go over screening. What are the goals? Who do we screen? When? How do we make the diagnosis? What are some of the contemporary imaging that we have? How are biomarkers used in identifying prostate cancer? And then just going over some of the treatment options for localized disease. So the prostate gland is a small gland, usually about 30 grams, and it sits tucked in between the bladder and the rectum. It can be easily palpated with the finger. The prostate gland can grow very large. And typically, if you have a large prostate, it doesn't necessarily mean that you have prostate cancer. And there's something called BPH, benign prostatic hyperplasia, which is the other pathology. It's benign, it's non-cancerous, that we often see in men as they age. And it's part of the urethral channel. And so as the prostate enlarges, it can compromise urine from leaving the bladder and cause urinary symptoms. Interestingly, when prostate cancer is found, typically it doesn't cause much in the way of lower urinary tract symptoms. It's a reproductive organ. It contributes to semen. And really, common in men, but 1 in 8 men in the US will be diagnosed with prostate cancer. And really what we're trying to do nowadays is maximize the detection of intermediate and high-grade cancers. So there's a difference: low, intermediate, and high-grade prostate cancers. We really want to not find the non-life-threatening cancers, the low-grade cancers, and really focus in on who are the men that's going to have the intermediate and high-grade cancers, because those are the ones that are going to take lives for early diagnosis. And then the goal is to really decrease unneeded biopsies. I think prostate cancer screening got a bad rap many years ago just because we were diagnosing a lot of men with low-grade disease. We were treating them aggressively, and it led to a lot of side effects for a lot of the men. So now we're just focused in on the men that really need treatment. So this is a hypothetical male, 62-year-old, comes to me. He's got an elevated PSA of 5.4. There's really things that we can do to rule out any kind of infection when when men come to see us, by a lot of different societies. One of them is the American Urologic Association guideline. The other one is the National Comprehensive Cancer Center. And they all have position statements on early detection. And this implies screening, so detecting cancers at a phase where a man normally wouldn't have any symptoms. And so if you're under the age of 40, you really don't need a PSA. We strongly recommend what we call shared decision making for men in between the ages of 55 and 69. So this is a conversation men need to have with their primary care providers. What is my risk of prostate cancer? What are the benefits I can if I find prostate cancer early? Anyone over the age of 70, we don't recommend routine PSA screening, but there's certainly men that come to see me over the age of 70 that will benefit from getting a PSA. How do we find prostate cancer? What I'll normally do is I'll repeat the PSA, just make sure it wasn't a spurious result. And then I always do a digital rectal exam. I think it's fallen by the wayside sometimes with primary care providers. And really, we just need to be advocates for ourselves, for our family members. What was my rectal exam? Was it normal, abnormal? Because this really guides you. Because even in cases where the PSA is low, you may find a prostate nodule that is suspicious. They're best in combination. And we routinely recommend that this is done annually in the men in between the ages of 55 and 69. In order to make the diagnosis of prostate cancer, you really need a prostate biopsy. PSA stands for prostate specific antigen. It's really only produced by the prostate. So if the prostate's there, you will have a value. If the prostate is removed, the value should be 0. The good news is it's only made by the prostate. And then the bad news is there's multiple different things that can cause the PSA to be elevated. So we can easily rule out some of the kind of common causes of an elevated PSA pretty quickly. It's a biomarker. It's used in screening when we make the diagnosis, after treatment, and in advanced disease. So you really need to know what your PSA values are. Most agree mass screenings are in the past. We used to do this, and really it's individualized risk stratification. There are some limitations with PSA, and who gets screened is often dictated by primary care providers, and there's still primary care providers out there that don't routinely check the PSA. We think there's definitely a value for checking the PSA. Who gets biopsied and diagnosed is often dictated by us, the urologist. So if the PSA is under 1, I would say that this is low, very normal, and you can repeat testing at an extended interval. In between 1 and 3, you may want to repeat testing sooner, about every year. Anything over 3, you really need an evaluation by a urologist, especially if you're in the ages of 50 and 59. 2.5 is or more is considered abnormal. We sometimes will use certain ultrasound measurements to get an estimate of the prostate size, and we're really focused in on what's called the PSA density. So if you have a very large PSA or a very large prostate and a very low PSA, that patient's going to have kind of a very low PSA density. So if you have a very high PSA and a small prostate, that's a high PSA density. Those are the ones that patients were a little more concerned about. So I've repeated the PSA, comes back, it's still abnormal. This man will get a multiparametric MRI of the prostate. It used to be that we would offer a biopsy right off the bat, but we found that there's a lot of benefits in getting the multiparametric MRI up front. Insurance is now covering this, and we get a lot of information from the MRI. What is the prostate size? Is it more consistent with a benign enlargement, or are there any suspicious lesions? The MRIs used to be done post-biopsy in patients that have had a negative biopsy and the PSA is still rising. Now we recognize the value of an MRI. It's beautiful pictures, and we get a lot of information about the anatomy, the lymph nodes, the bones right up front. And we're able to give it a PIRAD score. If there is a lesion, what's the score? It usually goes 1, 2, 3, 4, 5s. Rarely see 1, 2s. 3s we don't typically biopsy, but 4s and 5s, these are the ones that we really want to target with our biopsies. So I had an MRI. What's the prostate size? Do I have any PIRADs 4 or 5 lesions? And doctor, what are you going to do about these lesions? If the prostate's really large and the lesion's pretty small, then we can target these particular lesions very well with ultrasound and MRI, and we fuse those together. So in real time, we can target the lesions, because there is a higher chance of finding prostate cancer in PIRADs 4 or 5 lesions. And so this is kind of standard of care nowadays. What the MRI tells me, if there's no suspicious lesions, then some of those patients will still get a standard prostate biopsy. And so there's two different approaches to the prostate. One is transperineal, so through the perineal area, the skin underneath the scrotum, and the other one is transrectal ultrasound. And then each one of those has just a standard. So I don't see any lesions. I would just do a standard biopsy of the prostate, 12 course typically. If there is a lesion, then the region of interest will also get biopsied separately. So at a minimum 12 cores. And then if there's a region of interest, then we will target those areas separately. It's going to tell us the grade. Is it Gleason 6, low grade cancer, all the way up to Gleason 10, which is a high grade prostate cancer. How much cancer was involved? How many of the cores were positive? Where is the location? And gives us a lot of information with which to counsel men moving forward, because not everyone's going to need treatment. So if you have a low grade prostate cancer and just a couple cores, you'd probably be a candidate for active surveillance. So it gives us a lot of information, the prostate biopsy. And then we will put men into different risk categories, and it goes from very low, intermediate, high, and very high risk groups. This will dictate if you need any additional imaging to see if there's prostate cancer outside of the prostate, and the lymph nodes and the bones are areas where prostate cancer tends to spread. Biomarkers, these are adjunctive, I would say, urine and tissue-based tests that we use in conjunction with an MRI, PSA, percent-free PSA. And really, this gives us the biological aggressiveness of prostate cancer. So there's a variety of different biomarkers out there. One that I use pretty commonly is a urine-based test that's done after a digital rectal exam. If someone is very hesitant about a biopsy, you can do one of these tests, and it puts them in a risk category. Are they likely to have a more aggressive prostate cancer? So it gives us a lot of information upfront before a biopsy. We don't use them routinely in all men. For patients with very low risk disease, we don't typically use the biomarkers, but oftentimes in men with the intermediate grade prostate cancer. This is another test, the Oncotype DX test. And so if someone's diagnosed with a low grade cancer, we can send off this additional biomarker to see, okay, in this particular gentleman, what is the risk of developing future high-grade disease? So there's definitely a role. It's not used for everyone. If the biopsy is positive, typically we will use the CT and the bone scan to look for distant metastasis. If your PSA is under 20, then you may not need any of these adjunctive images because the risk of metastasis is pretty low. PSMA PET scan is a nuclear medicine scan that's really changed the landscape for prostate cancer. There's something called a pharmacologic agent. It's tagged to PSMA, something that's really secreted by prostate cancer cells. And this will light up in areas where there is prostate cancer. It's used really in patients with advanced disease, or we think that they have disease outside of the prostate, to see if the cancer is localized to the prostate or in the lymph nodes. And it's even used abroad in cases where someone hasn't even had a biopsy. If it lights up in the prostate, then they can even diagnose prostate cancer without a biopsy. We're not quite there yet in the US, and but it's a very sensitive test for looking at prostate cancer outside of the prostate. If you are diagnosed with prostate cancer, there's a lot of treatment options, and they range from active surveillance, not treating you. And we use this mainly for low risk patients that have 1 or 2 cores of a low grade prostate cancer. And then, if you have an intermediate grade prostate cancer, then we would typically consider either radiation or surgery. In the low risk category, active surveillance is very, very reasonable. It avoids the side effects of surgery and radiation. And we choose active surveillance because this is not really a disease that spreads outside of the prostate, and patients may have other competing medical comorbidities, diabetes, cardiovascular disease, COPD, et cetera. You may be a little bit older. We have routine follow-up for a lot of these patients, and there are certain times where someone may fall out of active surveillance because the cancer has biologically become a little bit more aggressive. And so we're not ignoring patients, we're following them very closely for any change in their disease. The intermediate grade prostate cancers are either treated with surgery or radiation. There's a variety of different radiation options out there for someone who, let's say, didn't want surgery. And then irradiation is usually done combining radiation with what we call androgen deprivation therapy, lowering the male hormone, the testosterone. This works very well. I would say that there's really no difference in cure rates between radiation and surgery. A lot of it boils down to a patient's risk tolerance. If someone chooses radiation, oftentimes nowadays we are placing a hydrogel in between the prostate and the rectum to really spare the rectum from injury from radiation. So you may hear We're going to do space or fiducial markers, and these are markers placed inside the prostate, which allows the radiation to be more exact and just focus in on the prostate and avoid the bladder and the rectum. Fatigue is common. Urinary and bowel symptoms are common. Over time, you can have issues with erectile dysfunction. Surgery is often very difficult after radiation, but after surgery, radiation can easily be performed if the cancer comes back. Radical prostatectomy is removing the prostate gland, and it's a very good option for men who want to get the prostate cancer out. It works extremely well. Nowadays, it's done in a minimally invasive fashion. Men spend the night in the hospital, go home with the catheter in place for about 7 to 10 days. Recovery and convalescence is relatively quick. And I would say that a lot of the main side effects include urinary incontinence and erectile dysfunction. But with the latest techniques nowadays, men are recovering a lot quicker with minimal side effects. The last one I'll talk about is high intensity focused ultrasound. There's select men who have prostate cancer, but it's in a very defined area of the prostate. And you can direct high intensity focused ultrasound to just target prostate cancer lesion and avoid removing the prostate or treating the whole gland. And I would say not everyone's a candidate for high intensity focused ultrasound. I think that this is really for select men. And I would say that I think the indications for HIFU are not as common as other sort of treatment options. But in select men, I think that this is a very reasonable option. How can men be proactive after the diagnosis of prostate cancer? Smoking cessation, low dose statin, vitamin D, and metformin. This is one of the gurus from the University of Toronto, Dr. Klotz, who just sees a lot of men with prostate cancer and has been following a lot of men with low and also intermediate grade prostate cancers in Toronto. So in summary, prostate cancer, it's common. Its aggressiveness is quite variable. Earlier detection is obviously very favorable. And we really want to maximize detection of intermediate and high-grade prostate cancers. We can do this easily now with our imaging, with the biomarkers, and we really want to avoid finding low-grade, non-life-threatening cancers. Variety of different technologies to improve risk stratification, and then this has allowed us to be a little bit more comfortable with active surveillance. So very low and low risk disease, we would consider active surveillance. Intermediate and high risk disease, surgery or radiation. And then there's other treatment options that are becoming a little bit more common in order to kind of minimize the side effects of treatment for a lot of men. So thank you for your attention. Happy to answer any questions that anyone may have later on down the road.
Thank you, Dr. Wason. It's always a joy when you're a part of these events. And Darren, I would like to turn it over back to you.
Thank you, guys. And we'll be hearing from you guys in a little bit too. But before we bring on the AdMeTech president, we wanted to give a big shout out to some of the folks, some of the pastors and church leaders who helped make this night possible too by spreading the word. Thanks to Reverend Houston Creighton of the Lincoln Congregational Church, Reverend Ortez Vendros from the Full Gospel Tabernacle Church, Reverend Mark Lavalas from the Humility Church of Christ, Reverend Fred Eulis of the United Evangelical Christian Church, and Reverend Jeremy Battle, Western Avenue Baptist Church in Cambridge. Erin?
And I would just like to say the Apostle Edward Campbell, New Jerusalem Tabernacle of Prayer, Bishop Orlando Harris, New Life Christian Church, Moses Rodriguez from St. Edith Stein, Bishop Tony Branch, First VP Brockton NAACP and host of NAACP Forum, Steve Abrams, Brockton NAACP Veterans Affairs Committee, and Patrick Gore, NAACP Veterans Affairs Committee.
Well, folks, we can do an awful lot in this life if we put our minds to it. Our next presenter has done a lot of good with her time. She traveled here from a faraway land, believing in the promise of America. She made this country and our region better because she used her passion, intellect, and desire to help others live long and productive lives by dedicating herself to fixing some of the disparities in our healthcare industry, especially concerning cancer. Dr. Faina Stern has testified on Capitol Hill about improving diagnostic tools and other measures to help thousands of at-risk patients have better outcomes. Please join me as we welcome Dr. Faina Stern, AdMeTech President and CEO.
Thank you so much, Darren, for this introduction. I'm humbled. And I would like to really express my gratitude to many years of partnership to Brockton NAACP and to many people here, including you, and including Karen, including Leona, Steve Bernard, Phyllis, so many people. I would like to also express my gratitude to Dr. Sean Wason, who is one of the first prostate cancer experts who usually shows up, is willing to show up at these events, is willing to make a difference for so many people. And I would like to announce that AdMeTech Foundation chose Dr. Sean Wason for Community Service Award. Unfortunately, we cannot provide this award virtually, but Sean, you will be receiving our award by mail. Thank you so much for your participation in so many of these events. Thank you very much in joining us in making a difference for so many men. Another person I would like to introduce is Craig McClay, who is a patient educator for Prostate Cancer Equity Program. Craig, if you do not mind including your contact information, how men can reach you in case they will have any questions in the chat room, it would be appreciated. At this point, we've had so many technical challenges in this PowerPoint presentation that we started creating video of my presentation. And Julie, our wonderful intern, do you mind starting my video?
And thank you so much, Faye. I'm honored. Thank you.
It's our pleasure. Sean. My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation, a non-profit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. My thanks to Brockton NAACP for the long-term partnership and for the opportunity to take part in this event. Dr. Sean Wason reviewed recent advances in prostate cancer screening, diagnosis, and treatment. The main topic of my presentation is our Prostate Cancer Equity Program, launched recently to bring these cutting-edge advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate Cancer Equity Program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. I'd like to express my gratitude to the members of the Brockton delegation to the State House who made this program possible. For public awareness and education, our messaging centered on the importance of screening and early detection critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive during the same period of time. The centerpiece of AdMeTech's medical education is annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices. The latest 7th annual conference took place only a few weeks ago. This educational event showed a rapid advances in patient care. In screening, our summit supports clinical practice guidelines recommended by the National Comprehensive Cancer Network, consisting of over 28 leading cancer hospitals and their experts. High-risk men, including Black men and any individuals with family history of prostate cancer, are recommended to initiate discussions with their doctors about screening with PSA blood test at the age of 40. Average risk men should start screening at the age of 45. The first or baseline screening test in younger men is important for identifying men at risk of lethal prostate cancer long term, over 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, molecular imaging. This non-invasive diagnostics highlighted the importance of PSA screening and shifted past concerns about screening into a dustbin of history. For example, this diagnostic test can determine which specific individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection critical for saving lives, reduce unnecessary procedures such as biopsies and treatment, and optimize selection of personalized precision care for each man, including careful observation or active surveillance, minimally invasive, what we call focal interventions, when only a tumor or a part of the prostate is treated, or radical interventions when the entire prostate is treated with or without systemic drugs. High-risk individuals, including Black men, carry higher risk of both mortality and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, compared to white men, Black men are less likely to have precision diagnostics such as advanced imaging, molecular or genetic testing, and to undergo life-saving treatment. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. For example, in this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research, development, and large-scale implementation of prostate MRI since 1998. In 2013, Massachusetts legislature funded clinical trial of prostate MRI, which produced groundbreaking data that were presented at the summit in 2016. By early 2017, about 6 months later, MRI was recommended as the new standard of patient care prior to biopsy and prior to treatment. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics: MRI and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. Emerging data indicate the importance of genetic testing for high-risk men, Black men in particular, for selecting the most effective and appropriate treatment. With this precision diagnostics, we can now accurately determine if each individual has a slow-growing, harmless disease and needs only careful observation or minimally invasive procedures, or an aggressive prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic disease and detecting return of prostate cancer after treatment. For example, molecular imaging with PSMA has become available at the Dana-Farber Cancer Institute since August 2021. On the left, right here, we can see a regular bone scan that shows no metastatic disease. On the right, however, we have molecular imaging that demonstrates extensive metastasis on the same patient. This information is important for selecting appropriate treatment. We are proud to have led research and development of molecular imaging since 2001. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference, with their multiple branches located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at high risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in this program take care of our families and friends. This process consists of three essential components. AdMeTech Foundation's team members collect basic information and match individual patient needs with the appropriate state's experts for clinical care. A clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, and financial assistance if needed. If an expert recommends any next steps, such as, for example, further diagnostic, evaluation, or treatment, AdMeTech's team and patient navigator work with men on the appropriate follow-up. I'd like to share with you a few recent examples of how Prostate Cancer Equity Program has been making a difference. This is a case of a Black man with a history of prostate cancer who is currently being treated. On May 15th, his doctor informed him that his scheduled treatment could not be provided due to problems with the insurance coverage. He got upset and shared his situation with a leader of the Men of Color Health Awareness Program, MOCA, our community partner in Springfield. On late afternoon of Friday, right before the Memorial Weekend, he contacted us and appealed for help. Our primary goal was to restore his treatment as soon as possible. And we immediately reached out to Dr. Mitchell Sokolov and his team at UMass and secured their support. On May 30th, right after Memorial Day, UMass Urology provided guidance to this man how to address his insurance issues. By Friday the same week, on June 2nd, the insurance issue had been resolved, and the appointment with Dr. Sokolov was scheduled at the earliest opportunity in early July to resume his treatment. The following Monday, MOCA leader heard what happened and asked for a second opinion for his own urologic health issue and received an appointment with a leading urologic expert within a few days of his request. This is a story of a Black man in his mid-50s who was referred to us about several months ago in mid-May by Cambridge NAACP. This man was recently diagnosed with prostate cancer. He got alarmed when his urologist informed him that the best care will not be available to him due to his limited insurance. We connected him right away with the patient navigator at the Mass General Brigham. She obtained a referral from his primary care physician and secured approval from his insurance. By June 6, this man saw Dr. Adam Feldman, a leading clinical expert and one of our featured physicians. Dr. Feldman described various treatment options but recommended surgery, which was performed in mid-August. Emma Coyert and Erin Roberts, members of the AdMeTech Foundation's team, serve as the initial contacts for the Prostate Cancer Equity Program. When you come to us, our team will work with you, Mass General Brigham, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions or need assistance, please contact Emma or Erin by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention.
Wow. Wow, wow. Thank you, Dr. Stern. This is just, the PCE program is just amazing. We are the only ones that are doing this in the state of Massachusetts, and we hope to serve all men in Massachusetts. But I also would like to give kudos and congratulations for the summit that Dr. Stern and her team just did. I can't imagine, well, yes, I can imagine, because I've been working with them, all that it takes and all that is put in to pull off those summits with, you know, hundreds of doctors from all over the world that are doing research, treatment, and all that good stuff. And they always pull it off without a hitch. So congratulations on that work. And then just the PCE program, I mean, it doesn't get any better than that. And those case studies that Dr. Stern just shared are just amazing. And so in addition to those wonderful case studies that you just witnessed and listened to, at this time, I would like to introduce someone who actually couldn't be here with us today. However, we do have a short video because he is someone who took advantage of the PCE program as well and wanted to share his story. And that person is, some of you may know, some of you may not, but it is Kenneth Reeves. He actually was the first Black mayor in the city of Cambridge. He is a prostate cancer survivor, and he's also the president of the Cambridge area NAACP. So we will watch that video. So if we could get that on, that would be great.
My name is Kenneth Reeves. I am the president of the Cambridge branch of the NAACP, as well as the former mayor of the city of Cambridge, Massachusetts. My intention is to say a word about the AdMeTech Foundation and its offerings and benefits, particularly to communities of color and particularly to Black men facing issues with respect to prostate cancer. I would say that in Cambridge, we've been in the men of color health business for more than 25 years. And so we have a men of color health outreach. However, I think we've become much more knowledgeable about ways in which we can assist the men of our city. And we particularly have become much more knowledgeable about prostate cancer and its impact on particularly Black men, who are 5 times as likely to be affected by prostate cancer than white men. So that being the case, and I've dealt with prostate cancer theoretically, and then 4 years ago, I was diagnosed with prostate cancer. So I have my own journey. And after diagnosis, I was able to hear what my treatment options were. And I chose something called CyberKnife, which is a 6-day treatment where you go every day for about an hour. There is a laser approach to the cancer. And after that, I was able to be clear for almost 2 years. And then suddenly my PSA, or prostate specific antigen number, kept going up, and no one could figure out why. And I had many MRIs and other tests. And that's when I met AdMeTech, because I was describing this to a friend, and they said, "You sounds like you're lost in the maze of, what to do when your numbers are inexplicable." So I was in touch with our Dr. Stern, and basically I had to tell her there is a test that they don't have in Boston that I need to have. It's an imaging test. It's very advanced. It's in Europe, but not yet approved by the FDA. And she said, "I'll get it for you." And she was able to arrange it through Sloan Kettering in New York. So after much red tape and bureaucracy, I was able to get that imaging test, and it did find where the prostate cancer had moved to an area around my lung, which my doctor, who's a very important, famous department head at Dana-Farber, said he had only seen one case in his career, so he was pretty sure it wasn't to the lung. So I then learned that, the physicians are great, but they're not God. So I called him and said, "Guess what? I'm number 2. And after being number 2, I still have had to have these various questions that I don't feel competent to answer about what next steps should be in my medical care. So while I have a wonderful team at Dana-Farber, who Dr. Stern led me to, but even in all that wonderfulness, there are questions that I don't feel competent to answer. So she just 2 days ago helped me to answer 2 great big questions. So I think this is timely for you to hear that. In my big questions were whether I should participate in a particular study, which would, I'm now on a very expensive pill that has my PSA number at 00000. So this is $16,000 a month. And the question asked of me by my doctor is would I would participate in a trial which would essentially stop this pill, let the cancer come back, and then observe what that does with respect to the testosterone level. And the doctor also said, well, we don't get many Black men in trials, so we'd like to get it would be important if you were to say yes. And so this was hanging over my head like a cloud. I couldn't decide because I want to do whatever I can do that will be helpful to both science and to prostate cancer with respect to Black men, because self-interest is a wonderful motivator. Her immediate reaction was, not for you. Because you had one of only 2 cases with your particular doctor, the experience with people like you for such a trial is too small. And so you should be very thankful to the doctor, but it's not for you. Thank God for having a foundation that's devoted to navigating men of color through the maze of prostate cancer to be able, with a scientific point of view, give that kind of direction and consultation. So I must say that is great. I also got to talk to her about a second thing, had to do with neuropathy. And so I went to a neuropathy doctor who was the head of neuropathy at the Brigham and at Dana-Farber. I got a clean bill of health, meaning that whatever neuropathy I have is appropriate for my age and for my diabetic status. But then Dr. Stern introduced the issue of vascular. The neuropathy is basically your hands and feet. The vascular is the veins in your legs going down to feet. She suggested, well, maybe you want to see a vascular person too, to get the fullest picture of what's going on with the circulation. Trust me, I have a lot of education and a lot of good exposures, but I think what AdMeTech is offering is the possibility to get the best advice for the best care possible at this time. And I want all men of color in Massachusetts to have that. So I couldn't recommend this program more highly based on my own personal experience and those people who I can recommend. This is my story and my song, but I must say that I have been very much helped by the advice and direction and management of AdMeTech.
Wow. Wow. Again, thank you, Ken Reeves. What an amazing story and testimony. So I'll pass it on to Erin.
Yes, and I would just like to agree, excuse me, that was an awesome video that Ken Reeves is, to give it from perspective from the Black community. And I would like to turn it over to Dr. Stern to discuss more about prostate cancer and any questions that you may have out in the audience.
Well, any questions for me regarding prostate cancer or to Dr. Grayson?
Oh, so I have a question. So what is, it's kind of a 3-part question. So bear with me as I'm formulating this in my head. So what is the likelihood of a man who has prostate cancer, maybe in their 50s, 60s? The first part is, what is the likelihood that they would get it again? And then the second part is, if they do, and say they're in their 80s or 90s, are there treatment options? And if there are, what might those be?
Sean, do you want to address this question?
Sure. So, Leona, I guess what you're talking about is, what is the risk of recurrence? So if someone's treated for prostate cancer, let's say, assume they have localized prostate cancer in the 50s or 60s, they have an intermediate grade prostate cancer. I would say that the majority of those patients will be cured. And so surgery, radiation is typically curative for those men. I would say that there is a subset of those men, probably about 10 to 15%, that will have what we call a biochemical recurrence. So despite taking out the prostate or treating it with radiation, over time, they may start developing a rise in the PSA. A rise in the PSA after treatment would signal the prostate cancer has come back. And we'll tend to watch those patients for a little while as the PSA slowly rises. We'll look, to see where the prostate cancer has recurred. It could be locally, so around where the prostate was removed or treated, or it could be what we call distant metastasis. If it's spread to the lymph nodes or bones, then really the standard of care is androgen deprivation therapy. We can treat that male for a very long time by bringing down the testosterone. It's not necessarily curative, but it keeps the prostate cancer from really spreading or growing elsewhere. If someone has had their prostate removed by radical prostatectomy, those patients are typically candidates for radiation afterwards. If someone's had radiation up front, such as CyberKnife or brachytherapy, and the prostate cancer has come back in the prostate, then I would say that they're a candidate for what we call salvage prostatectomy. You could remove the prostate if it's, if it's still within the prostate by surgery. Surgery is a lot more challenging because the area is quite stuck. There's another treatment option called cryotherapy. So you could freeze the prostate. And so I think that that's one of the indications for cryosurgery is someone who's had radiation and the prostate cancer has come back within the prostate.
Okay, thank you.
No problem.
Any other questions from you, Dr. Mason, or anyone else who spoke?
I had a question, Dr. Stern. I was wondering if there's any, if they found any like hereditary aspects to prostate cancer. My dad had prostate cancer and I have 2 older brothers. So I was just curious about that.
Thank you for asking, Julie. Actually, yes. Your brothers are at risk because their father has prostate cancer. And unfortunately, the highest risk men have in with family history of prostate cancer when their father or brother is impacted. So your brothers need to start PSA screening no later than at the age of 40. There is another aspect of that, and that is that daughters of prostate cancer survivors have a greater risk of breast cancer. So, Julie, you need to be careful when you reach appropriate age. Right now, you're very young, but when you reach appropriate age, with mammography screening. Okay, and usually it is related to a family of genetic mutations, which is called BRCA, 1 or 2, and other similar genetic mutations. When there is a family of history of prostate cancer, it is actually important to get tested to see if you have the genetic mutations, because in the present, not every man with family history of prostate cancer has the genetic mutation, but if they do, they have a much higher probability of highly aggressive disease. So it is really important for them to talk to their doctors. Once again, it's men with history of particularly prostate cancer, in family history of prostate cancer. It is important for them to discuss with their doctors about possibility of genetic testing for this particular mutation that puts them at risk, at much higher risk of highly aggressive lethal prostate cancer. It means that these men and women of with family history of prostate cancer, women need to be careful with breast cancer screening, and men need to be careful with prostate cancer screening. Sean, do you have any other thoughts?
I agree with everything that you've said. Nowadays, we use genetic oncologists very frequently. So anyone that's diagnosed with high-grade prostate cancer, or if you're diagnosed with prostate cancer at an early age, we are sending those patients to a genetic oncologist who will offer testing for a lot of these mutations. And so I would say that that's been really a paradigm shift in the last probably 5 to 10 years. We are sending, patients more and more frequently for genetic testing, especially if you have, one of the types of prostate cancer that's, an aggressive variant or high-grade prostate cancer, or you're very young. So absolutely.
And for people with family history of prostate cancer, we also send for genetic counseling even before they're diagnosed with prostate cancer. Darren?
I wanted to ask, obviously, AdMeTech Foundation advocates and also pushes for using imaging to help detect where the prostate cancer is and so forth. I just want to give you a short story about my case, but I feel like the biopsy I had, it was random. I imagine, my urologist, I guess, shot 10 different samples, and we happened to find the tumor. But there are many cases where a random sample like that, you may not find a tumor and still have one. Is that correct?
Correct. But the current state of the art, it actually, we made it our mission in 1998 to end blind patient care and random biopsy and random treatment. And we achieved it when we developed first prostate MRI and then molecular imaging, particularly PSMA imaging, which are both currently used right now. But there are no, there is nothing 100% done either. MRI has been shown to be extremely helpful in detecting highly aggressive prostate cancer, in reducing unnecessary procedures. And yet there is nothing 100%. MRI is known to miss aggressive prostate cancer, although it's extremely unusual. That's why we created Summit for Medical Education, look at the advances in research and best emerging clinical practices. And we are looking at the emerging importance of integrating, not only integrating PSA data, histology data, degree of aggressiveness seen on histology, with imaging, with tissue analysis for genetic mutation, with urinary tests, with blood tests. And it is this combination of precision diagnostic tools that appears to be most helpful in determining which individual men need biopsy, what kind of biopsy, how to do precise biopsy as opposed to random biopsy, right? And what men need treatment, what men do not need treatment, and if men do need treatment, what kind of treatment will be the best. It is the combination of these diagnostic tools. Now, the problem is that not every, even expert in our state or elsewhere, have full knowledge. It's all new knowledge over the last 5-6 years. Not every expert has knowledge, full knowledge about this test. Not every expert has access to this incredible test and advanced therapeutic approaches. That's why we created Prostate Cancer Equity Program and chose doctors like Dr. Sean Wason and others who have full knowledge of what is available and full access, so that their patients will take full advantage of this cutting-edge advances.
Is it safe to say then, for those listening, if you're at risk of the disease, and if you go see your urologist and you're not in this prostate cancer equity program, it probably behooves you to ensure that you're faced with those specialists who do have access?
Exactly correct. And whoever comes to us for prostate cancer equity program will get the best of class care available today, anywhere in the world.
And Darren, one thing I would just say is that, we do MRIs up front in a lot of patients. Even if you don't have a lesion found on MRI, you have a 15 to 20% risk of still finding prostate cancer. So those men, they're not absolved of the risk of prostate cancer. We will offer them the blind or the standard biopsy. So there's certainly a role for the standard biopsy that hasn't gone away. Even if you have a lesion noted in the prostate somewhere, we don't just target that lesion. We do the targeted biopsy plus the standard. So in all biopsies, we're still doing the standard quote unquote blind biopsy. The MRI just helps guide us. We also want to target the lesions that are noted. So I just want to clarify that.
Absolutely. And over the last year, actually, it was very much highlighted at the last summit that brought the key researchers and clinicians together. And what they showed is what are the implications of lesions when they are seen on imaging, such as MRI or molecular imaging, and what are the implications of prostate cancer that is not seen on imaging. And the best data we have today indicates that when visions are invisible on imaging, they have much better outcomes. So even if imaging cannot see every lesion, this is, if we cannot see these lesions, they're most likely to have better outcomes. And yet the state-of-the-art care is exactly what Sean mentioned. And this is combination of imaging such as MRI and systemic, or what we call blind biopsies. Yes, please.
Yes, I have a question for Dr. Wason. It's a PSA question. What can cause, or what are the causes of a PSA number going up and down?
Thank you for your question. I would say the majority of the time we see benign prostatic hyperplasia, or BPH for short. And usually when the PSA fluctuates, goes up, comes down over a certain mean, then the majority of time we do biopsy those and find BPH. If the PSA continues to rise, then that's more suggestive of prostate cancer. I think it's important before the PSA test is done that you abstain from any kind of sexual activity or ejaculation 72 hours beforehand. Any recent manipulation of the prostate, heavy bike riding, urinary tract infection can all cause the PSA to be falsely elevated.
Mr. Penn, just to highlight what Dr. Wason was mentioning, we just had a call a couple of days ago with one of our former patients who described to us, we did not even know that, because we know patient stories, the ending of patient story, if you will, only if they share it with us. But what we heard was that someone in New Bedford got local care and PSA was elevated, and this man was referred for biopsy right away. But his wife got alarmed and contacted us, and we told her, look, why won't he refrain from sex and physical exercise for a week and repeat his PSA test? And sure enough, his PSA came back after a week of no sexual activity and no physical exercise, and basically physical wellness went back to less than 1, which is very, very low. And this man did not have to have unnecessary biopsies. So it's a very, and it's not the only case that we know about, of course. When miraculously PSA just go right down, and men avoid unnecessary biopsies simply by repeating PSA test, something that Dr. Wason mentioned. Does it address your questions, Mr. Penn?
Yes, thank you very much.
Any other questions for us?
Yes, I have a question. And it's both to you and Dr. Wason. This procedure or test that's available in Europe and has yet to be approved by the FDA. Can you talk more about that? And
Absolutely.
Please.
Absolutely. It's called molecular imaging. I actually showed an example of that. Another name for some forms of this imaging, for actually most popular ones, it's called PSMA imaging. That's what, when Mr. Reeves came to us in 2021, it was not approved by FDA at that time. By now it is approved by FDA, and it is actually quite widely available everywhere, including Massachusetts. At that time, it was available only in a few leading academic centers, including the closest physically was Memorial Sloan Kettering. So, and this molecular imaging is very, very important. And the greatest value that we see of this imaging right now is in staging. For example, if men have troublesome kind of intermediate or high risk, particularly high risk prostate cancer, this imaging can identify disease that no other imaging, including MRI, can see. So it is really important for staging, and staging in turn is very important for proper treatment.
And Dr. Stern, I understand that in some cases for this procedure, insurance companies don't initially approve, but some men have been able to contact you, and you've been able to actually. I wanted to know that process where you go to the insurance company and then voila, all of a sudden it's approved.
It's not because it's voila, but because there is no miracle. There is no miracle to that. When men come to us, it's basically men whose physicians did not contact appropriate experts who know how to work with insurance companies, and with the physician who can actually justify to what we call writing referral letters if needed to insurance company, justifying the need. Now, not every man need this very advanced imaging, but if men do need this advanced imaging, we are working with their physicians and with insurance experts to make sure men will get access to this kind of very advanced imaging or genetic testing or whatever else they need.
I know there's not one way to answer this. I wonder if you could tell the audience, if you could give someone, a typical patient who maybe didn't start with the prostate cancer equity program. They went to a doctor, a urologist. How will they know, or what's a sign that says, you know something, I could be a candidate for this molecular imaging process. I should go see the folks at AdMeTech Foundation.
I think it is really important to focus on something else, Darren.
Okay.
It's very difficult for men who are vulnerable and scared to figure out if they need this imaging or not. Their physicians may or may not know. First of all, my first question that I very frequently ask of men who come to us, whether first, did you see an expert? Were you comfortable with your expert? Did you feel you can trust your expert? And secondly, would you be interested in a second opinion before you have invasive procedures or treatment that cannot be undone? Okay, to be honest, I cannot think of any colleague that I've ever had who has a family member or a friend they care about and who would not want a second opinion, no matter who provided the first opinion. It's just two heads is better than one. Before you have invasive procedure, it is really a good idea to have second opinion, because sometimes invasive procedures cannot be undone. Related complications cannot be undone. Sean, do you want to comment?
I agree with you. I would say that at least at our institution, and I think what's becoming more and more common across the United States are multidisciplinary clinics. And so someone comes to us, we diagnose them with intermediate grade prostate cancer. Personally, I want them to hear from a surgeon, a urologic oncologist, a radiation oncologist, and a medical oncologist. And nowadays you can get almost all three visits in one sitting. And I think that there's just no better way to kind of get unbiased information from three different experts involved in the care. And then it gives you all the information that you need with which to make an informed decision. So I think that that's extremely worthwhile if you can get a multidisciplinary visit and meet all three experts. You're going to get the most information moving forward. And because you see a surgeon, they're going to be biased. Hey, this person's maybe a surgical candidate. But I think that these clinics are just absolutely invaluable for someone contemplating all their treatment options.
And basically, this is almost like a standard practice in leading tertiary academic institutions that participate in prostate cancer equity program, to have multidisciplinary panels that advise men at the same time or in closely to each other from different perspectives: surgery, radiation oncology, medical oncology, etc., what they would recommend for them to do. And when men sort of are wondering what the next step still are, they're welcome to come to our program and will help. Craig, do you want to comment why you're busy? Your schedule is pretty busy. You have a lot of projects. Do you want to comment why you chose to work with Prostate Cancer Equity Program?
Yeah, sure. Thanks for the opportunity. Well, I mean, it's multi-layers, right? And I think the most important layer of this is I am a man. I just made 50, and I'm a man of color. So I'm like right in that area where, you know, I should be looking at this. And most of my friends are men of color who are around the same age. And for me, it's all about us taking charge of our health so that we can be around for our family. I think somebody mentioned earlier, maybe Dr. Wason, but one of the gifts that I've always wanted to give to my kids and my family was to be there for them, to be like a tree, you know, that they can always just kind of find shelter, shade, and you know, whatever they need. But I can't do that if I'm not here. And so I saw this opportunity. I have skin in the game, and I know people that I can help, you know, proselytize or help pass the word on. And that to me is everything.
Thank you so much, Craig.
Sure.
I think it is probably a perfect statement for us to perhaps adjourn the program. And I would like to highlight again that prostate cancer has been a daunting challenge. We have had considerable advances in screening, diagnosis, and treatment, particularly over the last 5-6 years. And Prostate Cancer Equity Program and our team stands ready to support any man who is interested, who has any questions about screening, diagnosis, and treatment. Our call to action is help is here. Please let us know if you need help.
Dr. Stern, thank you. Thank you so much. Folks, as she said, we're near the end. And as promised, we'll find out who the lucky winners are of the Boston Celtics tickets and the YMCA family memberships. Leona will give us that. But before I forget, I want to thank everyone for coming. And I want to give a big shout out and a big hug to our NAACP president, Phyllis Ellis. Phyllis works tirelessly every day trying to improve the lives of others. She hears from people all across the city. She tries to help them when she can and gets her members involved. And we appreciate you supporting this program. I know
Thank you very much. Great show.
Okay. Can I have a drum roll, please?
All right.
Anybody have an October birthday?
I have an October birthday.
Oh, okay.
Say it.
Okay.
October
And-
25th.
And tell us your name, please.
Nicolau Tavares.
Nick. Oh, hi there.
How are you?
Good. So Nicolau Tavares. And we said a most recent. So Nikolai Tavares is the winner of the 2 Celtics tickets. Yay.
Thank you very much.
You're welcome. Okay, perfect. Okay, so then we have 2 other prizes, which are the 3-month memberships to an Old Colony Y. And so the first winner of that prize is Mike Alkins. Mike, are you here? Okay.
I am back.
Oh, there he is.
Okay, here he is.
Okay.
I love it.
In time for the prize.
Okay, so Mike, you have won one of the 3-month memberships to an Old Colony Y.
Thank you.
Okay, and Steve Bernard will be in touch with you so you can retrieve that prize.
Thank you very much.
You're welcome. And then the second one is going to go to Janitha Owens. I thought I saw that. Oh, yeah.
Right here.
Yes,
All right,
Janitha.
Janitha.
Get it to Ann.
Okay, Janitha. So you win the second prize for the Y membership. It's a 3-month membership, as I said.
It's a family membership too, right, Leona?
I'm sorry.
It's also a family membership too. correct?
Oh, yes, that's right. Family membership. Yes. Yeah. 3 months. And Steve Bernard can help you with retrieving that award. or that prize rather.
Thank you so much. Appreciate it.
Okay, so we've given out our prizes. Let's give them a round of applause, those that have won. All right, so Darren, I'll pass it back on to you.
Aaron, do you want to say a few words before we take off?
No, I would just like to share that being part of the AdMeTech team, it's always a joy being part of spreading information about prostate cancer, and the awareness and the program is very important. My father and my uncle were also diagnosed, and they're also in remission themselves right now. So this program is actually, very personal as well. So it's very important for us to try to, stay as healthy as possible, but definitely, always see your doctors in a timely manner. And we are here to help with expedited services. So I'd just like to thank you all once again for joining.
Thank you so much, Aaron, and for the doctors, for the participants, everybody who came. So thank you so much. This is an important program. This is a disease that's treatable. And if you get to it early, you should be okay. Problem is, a lot of us don't. And that's why programs like this exist. Right, doctor?
Yes.
Please call me for that YMCA prize.
This has been wonderful. I'd like to just say a last couple of few words here. This has been absolutely wonderful. It's just always a pleasure to partner with AdMeTech and to do these kind of programs, because it's nice to see that we have some longtime loyal folks that come on, and we always seem to get new people. So it's nice to see that. I just really hope that folks will come to other programs that we have. But, more importantly, I hope that you will share this information. The next time we have a program, tell your friends, tell your family. And also specifically share with them the PCE program, because I just think that this program, it doesn't get any better than this. If you can get connected to physicians that can get you the care that you need, and you don't have to stress and worry about it, it's a no-brainer for me. So thank you, Dr. Stern, and your amazing team. And thank you to my co-hosts. This has been wonderful, and I just look forward to our next program. So thank you all for coming.
Thank you.
Thank
Have a
you.
great evening.
Thank you all.
Thank you.
Thank you.
Thank you.
Thank you. It was a great program.